honor to be here again at the APAS. Greetings to Senior Dr. Sancheti. It was Teachers' Day yesterday, I think. So he's been one of the greatest teachers for most of us in India, and it's a great privilege to have him here in the audience with us today. Dr. Sancheti, morning, sir. Okay, with that, let me talk to you about basically indications for uni, and whatever is not indicated for a uni is for a total knee. So when do you do a uni? So when I look at a patient, I first think whether I can do a uni or not. And if I can't do a uni, then that patient gets a total knee. So how do you decide whether this patient is fit for a uni? You need to have bone-on-bone contact medially. That is a most important point. If you have just narrowing of the space, medial tenderness, whatever, as long as that joint space is there, I would not recommend a uni, and nor do the Oxford guys. You've got to look for some other cause for pain in these patients, because if you're going to do a uni in these patients, or even a total knee in these patients with intact cartilage, you're going to have a painful patient afterwards, and that patient is not going to leave you for a long, long time. Less common indication is spontaneous osteonecrosis. Most commonly it's on the medial femoral condyle, but it's sometimes seen even on the tibial condyle medially. Very rarely, 2-3% of songs are on the tibia, but most of them are on the medial femoral condyle. And that's a great indication for a uni. They do very well. They are in extreme pain when they come to you, especially during the fracture phase, where they have that subchondral fracture and the complete crescent sign. The moment you do this, they're very comfortable. The only thing you've got to be very careful that you do not overcorrect. You need to take off enough bone so that you do not put them into valgus, because these people have no contractures, no deformity, no osteophytes. So if you overstuff the medial compartment, they will go into lateral overload and lateral degeneration. So you've got to be careful there. You've got to make sure that the varus is correctable. You can do this clinically, but you've got to make sure that you don't do it in full extension. You've got to keep the knee slightly flexed, 15-20 degrees, to relax the posterior capsule, and then give a valgus and a varus stress. So once you're doing this, you can see that it's correctable. Then that's a great indication. You may also corroborate this with a valgus stress X-ray, and that will tell you the integrity of the MCL. Nothing really happens to the MCL in a varus knee, and we've shown that in our total knee experience. Now, what about the cruciate ligaments? We did this study many, many years ago with immunohistochemistry and histology of the cruciate ligaments, and we published this classification of the cruciate ligaments and the structural changes that occur in arthritis. And the most important thing is that we found beyond 10 degrees or so of deformity, you start developing structural changes in the cruciate ligaments, and therefore it may not be a great idea to do a uni in these cases with more than 10 degrees of varus. The other issue is this business of the preoperative alignment. Now, the Oxford guys really don't talk about it, but it's important for us because we see a lot of patients with secondary deformity in the femur, extra-articular bowing in the femur, and metaphyseal varus in the tibia. So if you do a full-length X-ray, often these go beyond the 10 degrees of acceptability of deformity. And that's something you've got to be aware of, and we published this in the Journal of Arthroplasty, that the preoperative alignment determines the postoperative alignment. Unlike in a total knee, whatever alignment you start off with, you're aiming for 180 plus minus 3. But in a uni, you're not doing any release, you're not correcting the deformity, and therefore what you start off with is going to correlate with what you end up with. So if the person is expecting an absolutely straight leg, you've got to tell them that that may not be the case in a uni. In fact, we published in ACTA last year that the alignment that you achieve will be equivalent to their pre-disease alignment. The other issue is how much wear should there be. So typically if you have anteromedial wear, then that's a great indication for a uni. The moment the wear pattern extends to the back of the knee, that implies that the ACL, even if it looks intact, may not be. So this is a paper that we published correlating the articular cartilage wear with the integrity of the ACL. So an intact ACL is important. And this is an earlier paper from John Goodfellow showing the effect of the ACL being intact or absent on the survivorship of unis. And you can see in the absence of the ACL, the survivorship drops significantly. The patella facet should not be affected, especially laterally, and the lateral compartment needs to be intact. Flexion should be more than at least 100 degrees, and the flexion deformity should be less than 10 degrees. Now, if you're in doubt, do an MRI scan, and here you can see the patellofemoral joint is significantly damaged. So that might be a contraindication. You should also check the ACL if you're in doubt, and the lateral compartment, especially tears in the lateral meniscus. And finally, you should do an intraoperative inspection of the joint to make sure that you are okay with proceeding with a uni. And all our patients are consented for a total knee replacement. So if we find that the condition is not appropriate either in the patella, the ACL, or the lateral compartment, then we have no hesitation in switching to a total knee. And in the last 21 years that I've been doing unis, we've had to do this only 5 times. 2 because it seemed to be rheumatoid, 2 because the ACL was not good and the wear pattern went right to the back, and in one case we had significant patellofemoral changes. Exclusion criteria are if there's a prior HTO, inflammatory arthritis, and obesity. The relative contraindications, and this is something that we see more from our own perspective. If the opposite side has had a successful TKR, it may not be a good idea to do a uni. If the patient wants a TKR or has been referred for a TKR by somebody very influential, I don't think you should convince him to have a uni. Don't convince a patient who's not convinced or is unaware about a uni. You can tell it to him, but if he's resistant to it, it's not a good idea. We have a lot of our Indian patients whose son or daughter stays overseas and they have not even heard of unis. They just want a total knee done, so that's another reason not to do it. And lastly, we have a big business community who says, why do, if half a joint costs as much as a total joint, just do a total joint. Don't do a half joint. So these are some relative contraindications. Age really is not a barrier, and there are several papers which show that even in the elderly age group, you have comparable rates of complications as well as revisions. Even in the age group above 80, you can consider them for surgery if they fulfill the criteria. In fact, they do very well because it's a smaller operation, the rehab is much quicker, and it's a much safer procedure. What about high BMI? How much wear is acceptable in the patellofemoral joint? So there's this paper looking at 1,000 knees prospectively, and they looked at the Cosin and Scott contraindications. Age less than 60, weight more than 80, high activity level, chondrocalcinosis, and exposed bone. And the American Knee Society scores were no different with or without these contraindications, and the long-term survivorship in fact was also no different with or without the contraindications at 10 years. And the 15-year survivorship as well showed in fact that the ones with the contraindication, the so-called Cozen-Scott contraindication, had a better survivorship. Just remember that some of the fixed bearings may not be performing as well, and some papers have shown a high rate of wear of the polyethylene. So this is just few. Can I just talk for a few seconds? This is just using these indications. We've done a little over 1,000 Oxfords, and quite a few in the younger age group under the age of 50. And our early results have been published in the Journal of Arthroplasty. Most of them get a very good range of motion. They can sit on the floor, and our minimum 10-year follow-up has been excellent. We followed them up, and the change in the other compartments is minimal. And this is the results of our telephonic questionnaire of these patients with a minimum 10-year follow-up. And you can see that only 2 to 4% were somewhat dissatisfied in terms of result, overall result, pain, indoor activities and outdoor activities. So patient selection is the key. Careful history examination, x-rays, stress x-rays, MR scan if in doubt, intra-op inspection, take consent for a total knee. The Cozen-Scott contraindications are not supported by the long-term studies. Thank you very much.